Right. Sorry, everyone. I just realized I've been muted. Oh, so sorry for the blunder. Right. Too excited to meet everyone tonight. Right. So sorry about that for that technical so-called mishap. Right. So right. Once again, good evening, everyone, and welcome to another edition of our monthly Facebook Live Talk session. Right. My name is Andrew. Right. 大家晚上好，非常高兴的再次能够看到大家。今晚来跟我们一起参与今晚的讲座。说，假如你还没有跟你的朋友跟你的 Kaki 分享今晚的这个讲座的话，现在赶快分享出去。So if you have yet to introduce our Facebook Live talk show to your friends, your kaki, and your family members. So it's still not too late to share this session and let everyone, join us for tonight's session. Now, as I say earlier, my name is Andrew. I'm the head of fundraising, marketing, and volunteer management at 365 CPS and your host for tonight's session. Now, tonight's topic is understanding prostate cancer, and it's kindly brought to you by 365 Cancer Prevention Society and Icon Cancer Center. So once again, please like, share, and also comment so that we know you guys are all ready for the session. Now, remember, it's not just a topic for males, but it's also for anyone who is concerned about your health, concerned about cancer, and of course your loved ones. So please, feel free to join us for this session, and also get your friends to join us too. Now, 365 Cancer Prevention Society was founded in 2003 as a social service agency with IPC status, and is a full-fledged member of NCSS. The society mission is to serve the community through holistic cancer prevention measures. This is accomplished through health and nutrition education, promotion of healthy lifestyle, and lymphatics detox exercise programs. We also provide practical and emotional support and care for patients and their family members in their battle against cancer through residential and hospital visitations, counseling, and wellness services. So remember, one is never alone in the fight against cancer. We hope you can also join our community in the fight against cancer today. Now, for more information and to stay to date about 365 CPS, our activities and events, do visit our official website, follow us on Facebook, Instagram, Telegram, and don't forget to like, share, and comment on our social media pages so that more people can benefit from our charitable work, including tonight's session, please. Now, I'm going to introduce a very important fundraising campaign that we have in store, and we have been doing this for quite a while, right, with the great folks from Icon Cancer Center. Is the My First Memo, right? My First Memo fundraising campaign is put forth by 365 CPS and also the wonderful folks from Icon Cancer Center. It is perpetually a life-saving ground-up initiative to empower women 40 years and above from lower-income families to come forward to receive a mammogram. Early detection saves lives, so do your part in saving another by donating generously. Details are on our Facebook page, online donation portals, giving.sg and Give Asia. We only just reach the halfway mark for the target. So as they say, December is the month of giving. So do give generously and tell your kakis about it, please. Now, okay, some of you may ask, who are these people from Icon Cancer Center? Now, Icon Cancer Center Singapore is a specialist oncology group with 9 specialist clinics located across the island in all the major private medical centers. Now, Icon has a specialist team of 10 medical oncologists, 2 hematologists, 1 pediatric hematologist, oncologist, 2 radiation oncologists, and more than 30 visiting surgeons providing a full suite of cancer treatments for the public. And we are honored to have one of their senior consultant, Dr. Robert Lim, as our speaker for tonight's session. Now, before we proceed with tonight's program, kindly note that all information shared at this session by the speaker and 365 CPS are for general information only and subjected to changes. So do consult your doctor for personalized and detailed medical advice if you have any. We respect your privacy, so please make sure that your questions are not too personal and it's something that we can share with the rest present here tonight. Also, do let others have a chance to ask their questions too. Now, thank you. Now, prostate cancer. Let's talk about prostate cancer. Now, prostate cancer is actually cancer that occurs in the prostate. The prostate is a small walnut-shaped gland in males that produces the seminal fluid that nourishes and transports sperm. Now, prostate cancer can be said as one of the most common types of cancer here in Singapore. Now, so tonight's guest speaker, Dr. Robert Lim, he is going to talk to us about prostate cancer, and he is a graduate of both the University of St. Andrews, University of Edinburgh, where he obtained his medical degree. From 2005 to 2011, he was the head of Department of Hematology Oncology at National University Cancer Institute, Singapore, NCIS. In particular, the focus in developing new drugs treatment and enhancing the understanding of the unique problem for Asians with cancer has helped many patients and their families. So let's give a warm welcome and thank you, Dr. Lim, for joining us tonight. I will now pass the time over to you, Dr. Lim.
Thank
Hi,
you,
good
Andrew,
evening,
for
Dr. Lim.
thank you for your warm welcome and kind
Mm,
introduction. Welcome to everybody. Thank you
mm.
for spending this precious Saturday evening time, with us. And we hope that this session will be very helpful, enlightening to you and your family as well. So I'm just going to start sharing screen now and get the presentation going. Right. So the topic tonight we've chosen is, a very broad sort of a heading of understanding prostate cancer. You'll see that I'm a medical oncologist, so I will touch upon many different aspects of treatment, which actually include surgery and radiation. But of course, my own particular field of expertise is in medical oncology. A brief overview of all these issues is the outline here. So from incidence and risk profile, talking about risk factors, prevention is always something that a lot of people are interested and keen to hear about. Then moving on to the actual issue of when you have prostate cancer, be it early, localized, the sort of options for surgery, radiation, or even observation. And then finally, of course, we unfortunately do and will see advanced and metastatic prostate cancer. So how to deal with this, okay? Now, in terms of incidence, this is data from the Singapore Cancer Registry from the period, as you see on the top, 2010 to 2014. And for this period, prostate cancer was the third most common cancer in males. Most common was colorectal cancer, followed by lung cancer, and prostate cancer was third. Now, when we move on to a more recent period from 2014 to 2018 from the Singapore Cancer Registry, you see that the incidence has actually crept up to the second most common cancer in males. And then I just mentioned that the mortality rates have been reported at this point of time, showing that prostate cancer is the fifth most common cancer cause of death. Now, again, just depicted in terms of a table and numbers, you see prostate cancer in the period 2010 to 14 was the third most common cancer in males, 12.4%. And again, in the more recent times, it was second most common. And again, highlighting that mortality now reflected in this table shows it to be the fifth most common. So what are the risk factors for prostate cancer? The first and foremost, most important risk factor for the development of prostate cancer is actually increasing or advancing age. So it is rare in men less than 40 years of age, but thereafter, the incidence actually increases progressively. Now, we all know, and we have heard many times, how Singapore is being reported, like many other nations, to have an aging society. So this, in many ways, actually reflects or is the main reason for the increasing incidence of this cancer in males that I just mentioned. There are also genetic factors. For instance, DNA sort of repair genes. An example here is the BRCA or the ATM gene. And these may actually play an important role in the development of certain cancers, including prostate cancers, and may at times also be associated with a more aggressive disease. Now, how about the issue of diet, hormone levels, obesity? Well, these roles appear to be rather more limited or not entirely clearly associated in general with risk for prostate cancer. To illustrate the point about age, in terms of finding cancer that was not actually detected, but in autopsy series, basically, the younger age you are, the lower the percentage from 2 to 8%. But as for each decade of age increases, you see the rate or the incidence of occult cancer being found increases as well. So testimony to the point that with increasing age, there's increasing risk for prostate cancer. Can prostate cancer be prevented? It actually can. In some randomized trials, which I'm going to address shortly, this type of drug, we call it 5-alpha reductase inhibitors. These drugs have actually been shown to decrease the incidence of prostate cancer. These drugs are actually typically used to treat a condition called BPH, benign prostatic hypertrophy, which is extremely common in virtually all males as we all age will have signs and symptoms of this, in terms of how one is able to pass urine not so easily as it is with time. However, one caution here is that none of these trials have actually demonstrated an impact on prostate cancer mortality by taking these medications to try to prevent the onset of prostate cancer. And I'll come to this in the next few slides. First of all, in terms of taking this kind of medication, there are potential side effects. Gynecomastia, which is basically enlargement of the breast tissue in the male, decreased libido or sex drive, and erectile dysfunction. These are some potential side effects of this type of drug. So you have to weigh that versus the potential benefits, which is also decreasing symptoms from what benign prostatic hypertrophy, should you have that. And all this should be explained to men, obviously, considering such chemopreventive therapy. Hence, in reality, it is not commonly recommended for this purpose. In other words, not really used to try to prevent prostate cancer. And if given, there is a need to actually monitor the serum PSA levels with levels adjusted for the use of this particular medication, and I'll come to that laterally. There are actually no data that actually support the use of other things, for instance, vitamin E or selenium for the prevention of prostate cancer. In other words, such studies actually have been done and did not find any benefit in this regard. So the first of two prevention trials in this that I just mentioned, the prostate cancer prevention trial. In this study, you can see it was conducted primarily in America because they talk about African American ethnicity. That's a risk factor as well. But age more than 55 or older, having a first-degree relative with prostate cancer, they all had to have normal examinations and a normal PSA value at the time of enrollment. And what they did find was that there was a decrease in the incidence of prostate cancer in the men who were assigned to receive this finasteride medication as compared with placebo. Placebo was a dummy tablet. And the risk was like 10.5 versus 14.9%. We talked many times in this regard about a relative risk reduction. So that 0.7 means there's a 30% relative improvement. There was actually a small increased risk in high-grade prostate cancer. That means prostate cancer with what we call a high Gleason score, 7 and above, if the people took finasteride, 3.5 versus 3%. Fortunately, this in the end did not really pan out to be of great significance, but initially there was of some concern. And very importantly, the bottom line, as you do see literally on the slide, is that the overall survival rates, whether you took the finasteride or placebo, were essentially equal at 78 and 78.2% respectively. The other trial using the other type of drug in this class, dutasteride, the incidence of prostate cancer was also significantly reduced. Again, this relative risk reduction of about 23%. The decrease was principally in cancers with what we call a lower Gleason score, not so aggressive, in other words, 5 or 6. There wasn't any particular reduction in the high Gleason score prostate cancers, and very importantly, again, mortality rates were similar in both groups. Now, because I mentioned this earlier, because these type of drugs actually can reduce the PSA value that we measure in the blood by approximately 50%. If men are taking this medication and they have a PSA checked, then you have to take this into account, that is actually artificially halved in a sense by this medication, so that you know that you're quite aware of any changes and what the changes might be, to make sure that you don't miss a cancer that's developing. Now, how about lifestyle factors? So lifestyle factors, in particular smoking, obesity, have actually been shown to increase the risk in some ways of prostate cancer, particularly aggressive or advanced disease. And modification of such factors will also have benefit for other conditions and issues, right? Your cardiovascular risk profile, other cancer types, you know, you're a smoker, of course, that's another risk factor, and also diabetes as well. So important to bear this in mind, that lifestyle factor changes, modification has its benefit in more than one way. When someone is diagnosed with prostate cancer, what kind of factors do we take into account to help try and determine suitable and appropriate treatment choices? So one, of course, is the extent of the disease, the stage. So very commonly or not uncommonly, we look at a TNM stage, tumor, lymph node, and metastasis findings. The histologic grade. So when you do a biopsy of the prostate and you find cancer, the pathologist will report what's called the Gleason score. And the higher the Gleason score, the number ascribed to it, the more aggressive in appearance it is, and the more aggressive behavior it tends to have. And at times, and I'll come to this again later, molecular characteristics will be also considered as well. The PSA level is something we consider. Estimating the outcome with the different treatment options, and that's for each specialist to also get involved and assist with that. The potential complications of each type of treatment involved, and therefore also the patient's general medical condition, their age, what comorbidities of other illnesses or problems they have, because all this should factor in. And finally, of course, each individual's own preferences about what they wish to do, try, and what they're willing to accept in terms of potential risks and side effects. As an example, for risk stratification, there are many of these in the literature, different groups and such like. So the European Society for Medical Oncology, or ESMO, has one which is reasonably simple and straightforward. You can think of it as a low risk, intermediate risk, or high risk situation. So a low risk situation would be a small tumor, you know, in terms of the T stage, T1 to 2A, a low Gleason score, 6 or less, and a low-ish PSA, not particularly high, in other words, and 10 is the cutoff. And if you go to the other extreme of a high risk, that's when if someone has a large tumor in the prostate, particularly high Gleason score of 8 to 10, and a PSA value of more than 20. And obviously, in between that would be the intermediate risk. So this sort of profile can assist the doctor in making an estimate of the issues and situation to also better inform the discussion and therefore decision about what to do. So now we're talking about the actual prostate cancer, and in this instance, I'm starting off with localized or early prostate cancer. That means it has not spread. So the preferred approaches for definitive treatment or therapy will actually include surgery, which is radical prostatectomy, radiation therapy, or even observation in selected individuals. And I'm just going to touch upon that very briefly. That is really a situation where if someone, especially if they're more senior in age, they may or may not have a lot of other medical conditions, and if the Gleason score as well in particular is not high. And that's, well, you can observe these patients, and because you know that in general the expected pace of disease may not be particularly fast and quick. But largely otherwise, if you're thinking of surgery in this situation, you're looking at surgery versus radiotherapy. And it's largely a matter of patient preference. For surgery, what we call retropubic radical prostatectomy is the standard approach for patients who choose this modality. And it's either done by open surgery, that means with a large cut or incision for the surgeon to get in there with his hands or his or her hands to do the job properly. Or nowadays, there's obviously the option now of minimally invasive approach, laparoscopic or robotic. Now, in experienced hands, both the oncologic, that means the cancer treatment results, and the frequency of complications are typically similar with both sort of techniques, whether it's open or minimally invasive. But the choice of which type to choose should also be based upon the experience of the surgeon that the patient is meeting with, since these sort of treatments or procedures are associated with a significant learning curve. Now, after surgery, if someone has adverse findings from the blood or the pathology specimen, such as positive margins where the surgeon removed the prostate, there's invasion of what's called the seminal vesicles, extra capsular extension, that means going outside beyond the capsule of the prostate, or actually still a detectable prostate, a PSA value, because after surgery, if you remove the prostate, it should be undetectable. In these scenarios, often we would consider post-operative additional treatment with radiotherapy. And in terms of complications, the most frequent complications associated with this kind of surgery would include problems with urinary continence and erectile dysfunction. Moving on to radiotherapy, this mode of radiotherapy called IMRT, intensity modulated radiotherapy, has largely become the preferred style of administering radiotherapy. It used to be, many years ago, it used to be something called 3D conformal radiotherapy, 3D CRT. And especially in men where there's consideration to give radiation to the pelvic lymph nodes as well, all those who are going to receive what's called hypofractionated therapy. That means many more radiotherapy split up into many more fractions over a period of time. There's also another modality called IGRT, image-guided radiation therapy. And this helps with the localization of the prostate each day prior to each treatment, because radiotherapy is given as fractions of treatment per day, once a day. And sometimes, you have concerns about movement or whether you target it properly. So IGRT is one kind of modality which can help improve on the localization of this, just in the event there's some degree of shift or movement in the patient. And IMRT appears to be actually less toxic at good equivalent doses of radiation to treat the cancer, with a reduction in exposure to normal tissue, because you're basically planning the radiation to hone down is particular on the prostate when trying to minimize radiation to the surrounding tissues. And therefore, it actually allows for better coverage whilst reducing the exposure, as I mentioned, to other structures like the rectum, the colon, small bowel, bladder, and the penile structures as well. So as mentioned, IGRT is this kind of technique that uses 2 to 3D images prior to each treatment, and then is able to help track the location of the tumor, surrounding organs, and therefore make adjustments so that the radiation is more consistently precise to actually target the prostate, which is what we want, and minimize exposure to other organs. Some other considerations for radiotherapy. I mentioned in the first heading here, role and duration of ADT. I'm going to come to ADT shortly, but ADT stands for androgen deprivation therapy. So reducing the testosterone level essentially. For men with high or very high risk disease who are treated with external beam radiotherapy, that's EBRT, with or without what's called brachytherapy, the addition of this hormone therapy, androgen deprivation therapy with the radiotherapy is shown to be superior to radiotherapy alone. And typically, most commonly, a 24-month duration of this ADT is given in this scenario. Brachytherapy is actually treatment where the radiation oncologist plans to administer very localized radiation to the prostate, either using seeds or tubes, that kind of thing. And there are guidelines from several groups that recommend this for certain unfavorable intermediate high risk localized prostate cancer situations. However, this is still a bit of a controversial area, and there's still some variation in thought and recommendations about this. There's also another modality of radiation called SBRT, stereotactic body radiation therapy, and it's basically giving a more intense, in a very simplistic way of thinking, very intense short bursts of radiation therapy to a certain area over a shorter period of time. But this is indeed something which needs discussion to see whether it is indeed suitable for the patient or not. Now, there's also been a lot of discussion, and in fact, in Singapore, it's already coming on block soon, the issue of what we call particle irradiation, such as proton beam therapy, proton irradiation as an alternative to external beam radiotherapy. But as this statement I'm making here suggests, it is the role is not fully established in this regard, and I'll share why. So what is proton beam therapy? You see in the top part of this picture, proton therapy is where the beam, you plan it such that it goes down to the tumor, and the radiation dose is meant to end more precisely just at that level and not go much more beyond that in a way. So it's meant to be able to plan for the type of radiation to go a certain distance, in other words, and just sort of stop there. Whereas conventional radiotherapy, actually, they what you call have an exit dose. In other words, it goes through that area, right? So that therefore, obviously, the potential for more radiation side effects may be there. That's the current thoughts and theory about this. But what do the present amount of data suggest? So, to explain this again, in terms of the proton beam, the theoretical advantage of this is what we call its dose distribution. In other words, you can plan it such that the proton beam, the majority of the energy is deposited at the end of a certain point. You plan how far down you want it to go. That's called the Bragg peak. But this radiation dose then falls off rapidly to zero beyond that. However, there can be some uncertainty about the exact location of this Bragg peak due to what we call tissue inhomogeneities. That means other factors considered, like bone, air, things like that, that can alter exactly the physics of this. So in theory, the proton beam is meant to actually allow the delivery of high doses of radiotherapy to the target volume, whilst actually limiting what we call the scatter dose to the surrounding tissues. How about this compared with external beam radiotherapy? So more and more proton beam centers are starting up, and indeed soon in Singapore, there are going to be 3. But there are actually, at this point of time, no published randomized trials comparing this type of therapy with the conventional radiotherapy that I just mentioned as well. And in one particular review performed by the American Society for Radiation Oncology, the conclusions were the outcomes were similar with proton beam therapy and IMRT, and did not actually demonstrate the benefit for the proton beam approach. So that's why I'm urging some caution about this. And these are the studies. Essentially, these were studies taken from databases where basically in the first study mentioned there was less gastrointestinal morbidity, but there was no significant difference in the frequency which patients require additional cancer treatment, right? No difference in other toxicities. In the next study as well, there was an initial decrease in genitourinary, that means toxicities to do with the kidneys and bladder, that kind of thing, at 6 months. But by 1 year, this difference had actually dissipated. There wasn't any difference at that point. And in other toxicities, there were not any significant differences. The costs as well, importantly, were as much as 75% higher. This is an American study, compared with conventional IMRT. So essentially, I'll leave out the last bit. Essentially, it just suggests that at this point in time, it's still a bit questionable whether proton beam for prostate cancer is definitely going to be the standard of care in this scenario. How about surgery? Just back to surgery, one last slide about that. So as I mentioned, retropubic radical prostatectomy is the standard approach, and it can be performed either open or minimally invasive approach. You need experienced hands to do this because the outcomes are similar in such experienced hands. For patients who do not have any tumor involving what's called neurovascular bundle, then the surgeon that can actually perform what's called a nerve-sparing type prostatectomy, which is associated with a faster return of urinary continence, lower frequency of impotence. And I mentioned this earlier, most frequent complication of the surgery is incontinence and erectile dysfunction. On the left of your screen, you see a cartoon depicting, open surgery. So you have a larger incision where the surgeon is able to probe and use his or her hands to get down to do the work, etc. Whereas a minimally invasive approach, like on the right, is when you have all these various scopes put in with small incisions to use that to manipulate and perform the surgery from the outside of the body. Moving on now to the last segment, which is about advanced and metastatic prostate cancer. What's the rationale of how we treat this actually? So in most cases, prostate cancer that has not previously been treated with any drug or systemic therapy is actually dependent on androgen or testosterone for continued growth. Now, this androgen production occurs primarily in the testes, which accounts for at least 90 to 95% of the total circulating testosterone. And this production is also regulated by this hypothalamic pituitary axis, which is therefore also utilized in terms of the treatment. And the adrenal glands will produce the remainder. So these observations provided the rationale for this concept of ADT, androgen deprivation therapy, which is a key component of the initial therapy for advanced or metastatic prostate cancer. Now, either alone or nowadays, sometimes in combination with chemotherapy or even other therapies. So this is accomplished by either bilateral orchiectomy, that's surgical castration, or medicines to achieve medical castration, that means to get a low testosterone level. In terms of the surgical approach, it is actually, in terms of the surgery, it's a simple, cost-effective procedure because once that's done, the testosterone levels fall rapidly down to what we call castrate levels. And in many countries, this sort of approach does remain the standard of care because it is simple, cost-effective. When you're done, that you don't need to take any more, you may not need to take any more medications at that point of time. So this may also be particularly helpful when you need a very rapid decrease in the testosterone levels to get a more rapid response. For instance, someone with an impending compression of the spinal cord, obstruction of the urinary tract outlet, or sometimes also cost or adherence to medical therapy are an issue. The medical approach means giving medications, which are injections, which ends up decreasing testicular production of the testosterone through its effects on this hypothalamic pituitary axis. And the most commonly approach is continuous injections with gonadotropin releasing hormone, so we call it GnRH agonists, and that ends up suppressing the production of testosterone. If you can see on the left here, you see in this picture, in the brain, the hypothalamus sends a signal typically to the pituitary. The pituitary sends another signal down to the testes to produce testosterone, and that is what typically initially drives the prostate cancer. So with the one type of these medical drugs, the GnRH agonists basically actually initially stimulate the further release of testosterone, but with the chronic administration of this, there eventually is a drop in the testosterone level. That's what we've been using for many, many years. More recently, there have been what we call GnRH blockers. So you can actually give a medication which blocks that signal you see, between the pituitary and the testes, and you get a rapid drop in the testosterone levels from that. So these are options. Now, for men who have locally regional recurrent, it may be non-metastatic, but also metastatic disease, immediate rather than delayed this hormone treatment is preferred. And for men with what we call high-risk disseminated CSPC is castrate sensitive. That means it's still going to should be sensitive to the hormone therapy, castrate sensitive prostate cancer. The combination of this hormone therapy with some of these other newer drugs, abiraterone, a chemotherapy drug called docetaxel, another androgen blocker called enzalutamide and such like, significantly prolongs overall survival compared with ADT alone. One mention about docetaxel here is a chemotherapy drug, and when you combine this with the ADT, this has been shown to be quite helpful and good in controlling, reducing disease and prolonging survival for patients in particular with what we call high volume metastatic disease. So visceral metastases, that means disease has gone to the organs like the liver or lungs, that kind of thing, or where there are quite a few bone metastases, 4 or more bone metastases, and at least one outside the vertebral bodies of pelvis. Now, but none of these approaches have been directly compared with each other. So the choice of the regimen should include the discussion about the disease extent and about the potential side effects, toxicities, duration, and cost as well. Now, with the initial treatment of the GnRH agonist, as I mentioned, there actually is an initial increase of the testosterone level. So actually in this situation, it's important to prevent what's called a flare, because the initial testosterone levels going up can cause the cancer to increase. And this can be achieved with what we call anti-androgen drugs like flutamide, bicalutamide, and it's not usually a problem in that situation. I mentioned as well the GnRH and RH antagonists are an alternative to the others because you can get a very rapid decrease in testosterone levels as well. I'll skip the next one because of time. So side effects of ADT. So these include things like loss of lean body mass. You think of it this way: you are actually decreasing testosterone levels. So what does testosterone do for the person? It helps maintain lean body mass. So you also get decreased muscle strength. It can affect sexual activity, loss of libido in particular. You can get osteoporosis over time as well, loss of bone mineral density. You can get hot flashes in someone, as well, vasomotor instability, gynecomastia, decreased body hair. In other words, some degree of breast tissue enlargement, fatigue, lack of energy, and also some cardiovascular metabolic abnormalities. I mentioned this too, that nowadays we often will actually consider for the patient with advanced prostate cancer to combine ADT with another drug. And there's several options. One is this option of abiraterone with steroid prednisolone. So abiraterone is another one of these drugs which actually blocks the intracellular conversion of the testosterone in the testes, adrenal glands, and prostate tissue. Initially, it was shown to be helpful in disease that was not sensitive to hormone therapy already. And latterly, they did studies that used this in the earlier setting before it became castrate resistant, and found that patients as such had prolonged overall survival compared with ADT alone. One of these important trials that we refer to is called the STAMPEDE trial, and it showed this benefit of adding abiraterone to ADT in both the metastatic and non-metastatic locally and regionally advanced disease. Docetaxel is the chemotherapy that I mentioned as well. So this is sometimes also considered to be combined with ADT. Again, it showed improvements in what we call progression-free survival, and that means no progression, and overall survival in patients with metastatic castrate-sensitive prostate cancer with ADT compared with ADT alone, particularly this what I call high-volume disease. And other drugs is called like enzalutamide or apalutamide as well. Again, also showed benefit with the addition of this to ADT. But in terms of the choice, there are no trials which compare any of these amongst each other. And given this situation, the choice of the specific treatment, if combined treatment is to be chosen, has to be based upon a discussion with the patient about the extent of disease, the toxicities of each treatment, and as well as the expected duration and cost as well. So we end up many times having all these sort of algorithms to look at. I just draw your attention to the right side of this chart, looking at metastatic disease, and you can see that you have options of ADT plus docetaxel with abiraterone with prednisolone plus apalutamide, enzalutamide. So there are all these things that the oncologist and needs to consider and discuss with the patient. There are also radiation emitters, and these are typically targeting the bone, because the most common site of spread of the metastatic prostate cancer is the bone. And this particular treatment with radium-223, where it goes to the bone, has actually shown that compared with placebo, there was an improvement in survival, and also what's called first symptomatic skeletal event, like pain or fracture, that kind of thing. More recently, a different new other radionuclide, lutetium, has also shown very impressive results in the same sort of scenario in terms of improved progression-free, that means not worsening, and in terms of overall survival in the top, in the blue line, and also in terms of the time to the first skeletal event, like fracture, as I mentioned. And other things we look at nowadays too is to look at DNA molecular sort of issues. And in this particular study, they looked at this DNA repair defect. In particular, it was the BRCA2, BRCA, and ATM genes, where in these scenarios, patients who were given this drug, olaparib, is called a PARP inhibitor, had improved progression-free survival and overall survival compared with those who did not have this sort of feature. So in terms of molecular or genetic testing, first of all, touch upon what's called germline testing. Germline testing is actually when you actually test the person's own cells. So their own, for instance, white blood cells, what's innate to them, what they actually have been carrying all their lives, so to speak. And for all men, it is with metastatic prostate cancer, it is suggested to have counseling and germline testing for for both these things, what's called the Lynch syndrome. So you're testing for these other gene mutations in MLH1, MSH2, and so on. And also for the breast cancer susceptibility genes like BRCA, BRCA1, BRCA2, and all these others, because there are implications here for the possibility of considering, these type of drugs called PARP inhibitors. And there may be also a link here to suggest a hereditary component as well, and then counseling for the family and testing is sometimes that can also be considered. The other type of molecular testing is what we call testing for looking for what we call somatic mutations. These are mutations that actually only occur in the tissue, in the cancer tissue itself. So something has happened in there to give rise to these mutations. So that's why to look for this, you would have to test the prostate cancer biopsy specimen itself. So again, looking for mutations where they may be amenable to other types of drug therapy. So essentially, I mentioned here PARP inhibitors for those with what we call homologous, for HRR deficiency, homologous recombination repair. So it's a repair deficiency. Keytruda, pembrolizumab immunotherapy for tumors which are associated with deficient mismatch repair, or what we call microsatellite instability high, MSI high, and other types of mutations like TRK, the TRK inhibitors as well, which can be considered. This type of testing is sometimes referred to as next generation sequencing. So you take the tissue from the prostate and you run it through the special process to obtain the DNA, and then you run the DNA against a panel of many, many genes to look to see what you can find. It essentially is a search for mutations that we can choose a targeted treatment. And in this regard, there's also the option nowadays of looking for these mutations from the blood, because many cancer problems, when they are advanced, tend to shed or release their DNA into the blood, and the technology is now available to sometimes actually look for this from the blood rather than to have to do it from the tissue. You've all heard, I'm sure, about cancer immunotherapy. It has made a lot of breakthroughs in the past years already. And essentially, what is this? Well, these are what we call the current class of immunotherapy drugs are called checkpoint inhibitors. So you imagine that the immune system needs a set of brakes and accelerator to tell the immune cell when to do something, when to stop. And many tumor cells have found a way to actually stimulate or utilize the brakes. I put an arrow here, this PD-1 signaling system to tell the cell, the T cell, to go to sleep or suppress that. And these drugs essentially, antibody drugs, block this signaling and therefore allow the immune cell to be activated, and therefore, in this instance, to help try and fight and kill off the cancer cells. This concept of MSI high, microsatellite instability high, is a particular feature that where we have an approved indication to use immunotherapy, because patients who have any type of cancer which is MSI high have a higher chance of responding to immunotherapy. That's why we would look for it. Last but not least is one mention about bone health as well. So bone is the most common site for metastases from prostate cancer. There is therefore also a significant risk at times of complications, skeletal related events, we call it, and these will include things like pain, fracture, and even growth of the tumor in the bone to compress the spinal cord. We call that spinal cord compression. That's a major emergency that needs to be addressed. So how can we prevent this? And yes, we can, because besides the treatment itself that we mentioned, we also have drugs which are targeted to the bone in this regard. They are called osteoclast inhibitors, and there are two main types, the bisphosphonates and denosumab. And these have been shown to actually reduce the rate of incidence of the skeletal-related events. If a patient had not received any of these other earlier drugs together with the ADT hormone therapy, then become typically castrate resistant, and in that setting, then we consider other options like chemotherapy, which has improved survival for patients with advanced cancer, and another chemotherapy drug called cabazitaxel as well. So these are options that we know we can offer and discuss with patients in this scenario. So some conclusions, and that is that in early stage prostate cancer, there are options that range from surgery to radiotherapy, and as I mentioned, some select individuals, even observation. There are combination therapies for different scenarios. For someone who has a locally advanced prostate cancer but deemed to be high risk, beyond just radiotherapy, you may combine that with hormone therapy, and that has shown to have better outcomes than radiotherapy alone. And for the more advanced cancer scenarios, that beyond just the hormone therapy, ADT, you can consider additional options of androgen blockade or even chemotherapy together with the ADT. Germline genetic testing, next generation sequencing to look for options are obviously other things that we want to and should discuss with our patients. So thank you for your attention, and happy to take questions I'm sure you have. And I will now hand over back to Andrew. Back to you, Andrew. Thank you.
Hi, Dr. Lim. Thank you very much for your very comprehensive and informative content for all of us tonight. And I certainly hope everyone has picked up some useful tips earlier. And most importantly, remember, folks, early detection saves lives. As they say, a Chinese saying, 病从浅中医, right? So I know it is, when it comes to prostate cancer, it's sort of a very awkward and taboo subject for males, just like for breast cancer, similarly for the females. But seriously, it's when it comes to cancer, there's really no time and no need to have any awkwardness or shyness in seeking treatment and early screening as soon as possible. Okay, so now let's have some time for our Q&A segment, right? Do we have any questions from the audience, or Yeah, seriously, our audience tonight, our participants tonight, a bit too shy to approach this subject, right? I mean, if that's the case, then since I'm the man, one of the men in the house, and also the host, then let me start the ball rolling. Then, Dr. Lim, is family history a major contributing factor for prostate cancer?
So, family history is something to consider. We always want to take that into account when we meet a patient, to understand, because that alone can also just give us a signal to consider whether some of those hereditary components, testing issues that I just mentioned towards the end, may have a higher
Mm.
possibility of being found or not. And the implication there is that there could be treatment implications, and there could also be implications for the rest of the family to be aware about of their own particular situation. Now, having said that, like in all cancer problems in general, the chances of a cancer being linked to a family syndrome of cancer tends to be rather low in general. In other words, the vast majority of cancer problems that we diagnose and see are what we call sporadic. The incidence of actually true hereditary cancer problems, and this will include prostate cancer in this situation, maybe about 5-10%, thereabouts approximately, not particularly high. But we do want to pay and do need to pay attention to the issue of what's any family history. And family history may not necessarily just be of prostate itself. We may meet a man who has been diagnosed with prostate cancer and may then find out that maybe his mother had breast cancer, let's say age 40, an aunt with ovarian cancer around that time as well. And that may then suggest the possibility of that BRCA gene. So BRCA gene itself, although very commonly we always associate it with breast and ovarian cancers, there are other cancers involved, for instance, prostate cancer itself, but more commonly, obviously, would still be breast ovarian.
Okay, thank you,
Okay.
Dr. Lim. We have a question from Meng Hui. Right, his question is there any early screening program or basically early screening like a mammogram for breast cancer or even colonoscopy for colorectal cancer? I mean, available for prostate cancer in this case.
So actually, this sort of testing itself has been available for many, many years, and that is basically testing the blood for the PSA. Yeah. The thing that has, as opposed to like say mammograms and stool testing, colonoscopy for colon cancer, which is quite clear about the benefit, etc. There's always been this issue around prostate cancer about whether such testing actually does give rise to an improvement in prostate cancer related mortality. So there actually are proponents of that, and there are, well, the non-proponents, right, of that, because it has been a controversial area. So for the most part, you know, um, actual survival from this has not necessarily been improved. But at the same time, you can and will pick up such cancers. So there are various issues and nuances about this kind of thing, but suffice it to say that I think what is probably key is have a discussion with a doctor who knows you, your family, if this is the issue, to get a better feel for whether this sort of testing is indeed for you. Put it another way, you see, if you do a test, the test must be reliable enough to be able to pick up something at a point where the intervention is meaningful. At the same time, um, you have to bear in mind, if you have elevated PSA and you need to do biopsies, etc., the biopsies obviously have some attendant risk. It's not a high risk, right? But you can have such issues as well, and what you need to go through as well. So in this setting, as opposed to the even more established role of breast cancer screening and colorectal cancer screening. There is a role, but I would say that this role needs to be fine-tuned for the person as well, you know, and for the situation, for the family history, and all this needs to be taken into account.
Sure. Right. Thanks, Dr. Lim. We have another question, perhaps is more concerning a local context. Is there any particular age group that are much more of a high risk or should be more concerned? I mean, basing on a local context, and is prostate cancer? I mean, seeing a trend that is affecting the younger age group.
So the last bit of that question, I can say probably no. I don't think we have noted that there is such an issue. You know, as you saw
Mhm.
from my slides earlier, that it is really uncommon. In the younger age group, less than 40, and then thereafter it begins to pick up. But again, see, the question is, at what point of time is it so much more prevalent? That means more in that likely to be seen, that you would tend to pick it up. So typically, I would say that the common sort of age that's sort of discussed and used, or so, is 50 onwards as well. To start looking at that, if that's going to be something you wish to consider.
Okay, thanks, Dr. Lim. I'm just hitting 50, so you just send some alarm bells to me, right? To
Discuss
really
it
be a
with
bit.
your family doctor
Yeah,
as much as
we
possible
shall take
too.
this offline, I
Yeah,
suppose.
yeah,
Right.
yeah,
So
yeah.
it seems that once you hit 50, there's a lot more tests, right, that you need to do medically, right, to have a peace of mind. Now,
Mhm.
we have perhaps one last question from Jean. Right, Jean is asking whether any diets or food that we eat that can potentially lead to a high risk for prostate cancer. And what's your advice on this? I guess this is always a very Singaporean concern, being majority of us are quite a foodie, I suppose.
Yeah, yeah, we get
Yeah.
this question many, many times, and a very fair question, because,
Mm,
yeah, but essentially, no one has actually shown that keeping to any particular diet or so is associated with a lower incidence or higher incidence of prostate cancer in a particularly meaningful or reproducible way. Um, I mentioned this in my earlier slides as well, and this also includes things like vitamin supplementation and all that as well. So there's not been any clear association between that. I think my parting words, as always, for these issues, is a proper balanced diet is actually the most appropriate way to approach many things. I think in terms of your general health, and even for our patients who are on treatments as well, because
mm,
that's, to me, that's how nature is, isn't it? Not too much of
mm,
something. You look at your blood results, low is not good, high is not good. So so keeping to a situation where there's enough of all that's needed for the body is actually the most appropriate way to approach the
mm.
situation. Yeah, I
That's
hope
right.
that's of some help.
Yeah, thanks, Dr. Lim. Right, folks, you hear it from the doctor himself, right? In when it comes to eating, right? Eat in moderation, right? Too much of anything is probably not good for you. And for those who are a bit more concerned about your dietary, what to eat and all, I mean, we have tons of videos and informations and contents on our website, right? Telling you what are the good stuff to eat, how you should eat, and also perhaps some even simple recipes that you can have a go and try on to lead a healthy diet and also healthy lifestyle. So, right. So do check those things out. All right, if you are interested. And once again, thank you very much, Dr. Lim, for joining us tonight. And
Thank you
of
for having
course,
me. Yes. Hmm.
yeah. Thank you very much, Dr. Lim. Right. So thank you very much, everyone, for your participation. And once again, Dr. Lim, for sharing. And we hope that everyone has enjoyed tonight's session and gained much needed knowledge about prostate cancer. Now, at this point, I would like to really seek everyone for your assistance in giving us your feedback about tonight's session and also what other topics you would like us to feature in the future. Obviously, in 2022, because tonight is our last Facebook Live session for 2021. Right. So kindly scan the QR code on the screen, right, to do so, or you can click on the link in the comments section, right, to do so, right. We'll just give everyone a couple of seconds more to do that. Now, coming into 2022, right? So many of you would probably be very excited and so-called wanting to know what we have in store for everyone in 2022, the brand new year, right? And of course, whether the COVID is still going to be impacting some of our lives and the way we do things and go about our business. So um, our next Facebook Live talk session, right, would be on childhood leukemia, right? Find out about it, right? Seriously, even if you don't have a child, because it's a subject that we do hear much about, and not much is really known about it. Now, the speaker for that session would be Dr. Lily Ang, who is a pediatric hematologist oncologist from, once again, Icon Cancer Center. The session will be held on 8th of January at 8 p.m. over at 365 CPS Facebook page. I mean, right in the same space here, right? So you will see more information that is currently now fresh on the screen right now. So do join us then, right? Lastly, right, for more information and to stay up to date about 365 and Icon Cancer Center, our activities and events, do visit both of our official website. Follow us on Facebook, Instagram, and Telegram. And don't forget to like, share, and comment on our social media pages so that more people can benefit from our charitable work and services. Now, once again, thank you very much for joining us in 2021. On behalf of everyone at 365 CPS and Icon Cancer Center, we wish you all happy holidays and hope everyone have a safe and healthy new year ahead. Good night. Thank you.